So this case is a case of a patient who has had good LA classification, so reflux LA classification B before, has had a C0M1 Barrett's esophagus, for which he has had band ligation, which showed low-grade dysplasia before. All right, well, I mean, Alex, if you're not sure, let's break it down. So from what we said before, let's just ask our audience, because, you know, it's like Who Wants to Be a Millionaire? You've got an audience of 8 experts here. So is that cancer? Anyone thinks that's cancer? Right, so everyone's saying no. Why is saying no?
Because it's regular.
Because it's regular. Okay, any other reason why saying no?
Doesn't have any other features that would
doesn't have any other surrogate features. And the last final very important Delphine, now I'm going to call it the Delphine question about this is it associated with any other features of inflammation? Because I think that's a very important question. Like, is in the rest of the gastroscopy, is there any other inflammation present, or is it on its own? Well, you say, wait, hold on. You say you see there is a scar. Now, you're experienced. There are many people in the room who are not. What is it about that? You said retraction. So what does that mean? Explain to people why this is a scar.
So the mucosa is wider than the rest of it, and everything is pulling towards that point. So
yeah. So here I'm showing on the screen. Sorry, Alex. I'll show you later in a minute. But here I'm showing on the screen.
The structure.
Yeah, you see the wide on there for the guys in Ghent at the top, at the 2 o'clock position. And indeed, things are almost forming a ridge here, which is very common when you have got scarring, because, of course, everything's healing by fibrosis. And we know the patient has had, I've just told you that the patient has had a band EMR 3 months ago. So that is indeed the appearance of a forming scar. And so what happens when you get scar formation? Of course, you make a cut in the mucosa and submucosa, you get healing, it granulates, it looks a bit like an ulcer, and it starts to come together. And then the last part of healing is in the center of the scar, right? So this zone is just still healing from scar formation. So why don't we, Lov, why don't you have another look at the junction and show about any other features that might be interesting of the Barrett's? Why don't we start by, I think it's very important that we learn how to describe Barrett's and how much there is or how little there is. I mean, can you take us through how you do that here?
Me?
Yeah. Take us through how you talk about Barrett's, the length, how you think about the cap and the length of the cap, where you should measure, etc.
Yeah. So obviously you don't measure from the cap, but from the scope. So I start with the gastric folds. Usually, I guess you can start at top. So I don't measure from here because this is my cap. So you go in a little bit lower maybe, and then you're at your scope and you look, and you go from the teeth, not from the outside of the mouth guard. You basically, that's standardized from the teeth. So this would be 39. And then you look at the circular Barrett's. Is there any circular? Now, we all know you have to sometimes do a little bit of suction, because if you insufflate, the top of the gastric folds can get really flattened out. And I think we then often overestimate Barrett's. So you have to, you agree, Alex?
I definitely agree. Yeah, you have to deflate a bit.
You have to deflate
to collapse a little bit the esophagus, so you can assess the top of the gastric folds. Absolutely. And then you can measure. So
would you agree there is no circular Barrett's here?
No.
No. And also according to the British guidelines, or we don't speak of Barrett's when it's too short, do we? When it's half a centimeter, we don't speak of Barrett's.
So why don't you take us through how you would do that?
Okay. So what we do is we go to the stomach. We want to be fast on to the greater curve. Am I saying it correctly? You correct me if I'm wrong. So you want to be fast. You don't want to be like this, or I don't know, like this. No, you just want to be on
Why don't you
onto
show
it.
people, show people what you mean by the greater and lesser curve, because maybe people are not sure from this image which is the greater and which is the lesser curve, and how you can determine that from the endoscopic image.
So here's the greater, the small letter,
A letter,
sorry.
yeah.
And at the bottom maybe of the screen is the greater curve, and that is anterior wall and
And
posterior
posterior.
wall.
So I'm still
the
not clear.
greater-
If I'm the alien from Mars again, I'm still not clear how I can reliably identify from what you've just told me where the lesser and greater curve are and what orientation you want it in.
So I'm going to help Lobka here because it's in
Yeah.
English. So we're going to refer to clock face, and we're going to refer to the curvatures. So there's the greater curve, greater is bigger, it's longer. So the longitudinal axis of the stomach, the greater curve is the long one, and the lesser curve is the short one. So in the image as you're looking at it now, which is a neutral position for the scope, your greater curve is running from 9 o'clock to 3 o'clock, and the longitudinal folds of gastric rugae are running down towards the antrum. And as lob goes into the stomach and then rotates clockwise to get a normal insertion technique, your lesser curve is now above you at 12 o'clock. Okay, so you've got the greater curve underneath you running from 6 o'clock into the center of the screen, and the lesser curve is above you at 12 o'clock running from 12 o'clock into the center of the screen.
Then, Lob, just come back and show how you neutralize a position, because John talks about the neutral position of the scope. Maybe people are not 100% about what he's meaning by that. But what I think you're meaning, John, is when you insert it, the natural position the scope wants to sit. I guess it maybe a bit depends on what position a patient is, but normally they're in the left lateral if you're not doing therapeutics. So I agree with you that is a little, I would rotate a little bit clockwise to make it perfectly my neutral position, like that. Yeah, so I want to see the greater curve at 9 o'clock, the lesser curve at 3 o'clock, and then Lob's going to show you how you pull back into the esophagus to use that image to standardize your position. There are other ways, which we'll go into in a minute.
I think it's worth saying, David, that the reason we probably evolved with this position is because that's when your scope, your handling of the scope is neutral. So your left hand, your right hand are usually in the same horizontal plane. So you're nice and natural. There's no angulation or tip deflection on the scope, and the patient is in the left lateral position. So for most people, that would be a standard gastroscopy position. Like
it's worth mentioning before you do, Roland, that lesion that we resected is, guess where? In the 4 o'clock position. Yeah. I want to drive that point home if you're looking at Barrett's. Roland, yeah.
So, Lobka, can you drive in a bit to the stomach and get that neutral position again? Yeah. Right, just go slightly further. Okay. And now, yeah, no, not too far. That's fine. Yeah, no. So now what I want you to do is turn your body 45 degrees clockwise. Turn your body. Right. So the point here is that it's not just the patient lying in the left lateral position which determines what the neutral position is looking at. Now turn back to where you were. Do you see that the neutral position requires your body to be in the neutral position as well as the patient? Do you get my point?
Yeah, 100%. I think the other thing to say is why is it so important is because some people are not so used to looking at Barrett and take biopsies according to the Seattle protocol, and they say 39 3 o'clock and it says high grade, right? And they haven't recognized it. So if everybody thinks then 39 3 o'clock in the neutral position it's here, then it will be quite straightforward. But if you're not in the neutral position and you say this is the 39 3 o'clock, you'll be looking at something totally different. So that might be fine in a very short Barrett, but in a 10 centimeter Barrett, I think it can get really tedious, or so another reason to get it standardized.